member at the Turkish Diabetes Foundation. As I said, I'm the president of a nationwide patients organization, and I'm working as an ophthalmologist in the Florence Nightingale Hospital, and I'm also teaching as a professor of ophthalmology in the ophthalmology department of the Istanbul Bilim University. We are one of the countries which have the highest prevalence in Europe. Actually, we had a nationwide survey back in 1998, 7-8, and then in the year 2010. And when we had the nationwide, in both surveys, we had about 25,000 participants, and they were monitored by the World Health Organization European region as well, and the statistics were done in Turkish Statistics Institute. So when we go back to, let's say, the year 2000, about 2000, then we had the prevalence in adult population about 7.2%. And at that time, the estimated prevalence of diabetes in adult population in Europe was about 4.6%. So we were higher than the mean of the Europe. And then when we come back to 2010, the crude diabetes prevalence rate was 16.5%. I'm looking to my papers because I may be wrong. With the prevalence of diabetes in the adult population in Europe, the estimated, of course, 8.1%. So it's again very high. So during this 10 years in Turkey, the increase in diabetes was huge. So it increased by about 90%. The risk population, which, I mean, the IGT population, which is also called as prediabetes state, has increased about 106%, and obesity by 40%. So the things are not going well, let's say so. So I hope in the future we will have much better numbers. We don't have a nationwide survey, but in general, I can say it's cataracts, diabetic retinopathy, and the visual fluctuations, you know, due to the changes in the refraction errors. I mean, the refractive changes, fluctuating refractive changes are the most common ones. But among them, if you speak with the patients, then it's, of course, the diabetic retinopathy. This is one of the most feared complications of diabetes in Turkey. And I think it's like that also in many countries. I mean, this is, unfortunately, it's so, although the visual loss or visual impairment is preventable, still it's one of the most feared complications of people with diabetes. Now, I had the privilege to work in a diabetes team in the Istanbul Medical Faculty. So if the patient applied to the diabetes clinic, eye examination was part of the routine examination, the initial routine examination. And then, according to the, to the fundus findings of the patient, I was following them afterwards. But so, and the good thing is, again, I had the opportunity to evaluate the patient and also to arrange the screen intervals according to the patient's whole history, and also how his or her metabolic control is going, let's say so. So we had study from the patient, who applied to the to this clinic for during the 2 years. And then we diagnosed retinopathy in about 43% of patients many years ago. And the thing is, the prevalence of diabetic retinopathy was about 5% with duration of diabetes 5 years or less in people with type 1 diabetes. And it was about 20% in people with type 2 diabetes. So, and then we have also looked to the prevalence of diabetic retinopathy in patients who have more than 20 years of diabetes. In type 1s, it was about 79%. In type 2 people, in people with type 2 diabetes, it was about 77%. So the numbers, I think, have not that much changed. We had another chronic complications study, a nationwide one, which we run in about 23 or 27 centers. I don't remember it well. And then the people with type 1 and type 2 diabetes were also included. And then the prevalence was about, general prevalence was about 35%. But then we had the results from the Barometer study. If you look to the Turkey report, then the numbers are much lower than. It's wonderful. For example, about 1/3 of the people didn't know or didn't have any eye examination. But when you look at the report, then these patients were more regularly followed up. So it's a wonderful thing. I mean, I think the results are very much motivating for the diabetes population. About 60% of the respondents had a median number of visits 4 times per year. This is very good. And then nearly 30% seeing a GP or family doctor 4 times per year as a median number. This is also wonderful. And about 63% think their diabetes is controlled, which is again a high percentage. So this was a very good group, I think, because these were the patients who are more in contact with the diabetes organizations or with the, so we can see from here, actually these numbers show how the rates can be decreased if people are more aware, if people are well educated about diabetes and so on. But at the end, it's much lower than the percentages are lower than the percentages generally in Turkey. But as I said, I think I tried to give this example in many platforms because, again, it shows how it can be changed. There has been a significant decrease in the number of on-site consultations. So if the patient doesn't have any complaints or any significant because they were calling and saying we have some if it's not significant, they were trying not to come to the clinics for diabetes management. They preferred to have online consultations for a time. But as the hospitals, clinics, and people as well get more organized, and also when the time prolongs, people are getting more and more, they are losing their sensitivity towards COVID, let's say so, because they are not as much as afraid as at the beginning. They hear the numbers, the big numbers, the numbers of people who have COVID-19 or the number of the deaths, or not nice things, let's say so, but they are getting more and more insensitive. And they are now trying to get back to the normal life as much as they can. And they are coming back to the hospitals again. But still, so I can say a kind of hybrid. it's a very popular word right now, the hybrid. We will have this. We have this right now, and in the future, I think we will have this both face-to-face and online consultations together. So it's like that right now. Oh yes, because the thing is, as I said, people are afraid to come to the hospitals, and then they postponed or canceled their visits, and the non-urgent surgeries were rescheduled or postponed. So many things. The people had the people had also some difficulties reaching to their healthcare professionals. So, I mean, they had problems, but it's now getting better, more normalized than, I mean, this shock is over. It's good on one side, bad on the other side, because when the shock is over, people get more relaxed, and this is not good. Several alternatives for face-to-face consultations had been put in place. So one of them is, I mean, mainly the remote consultations. So this is of course more easy for the people because they don't have to go out or take the public transportation and so on. On the other side, if you speak with the people, with the patients, then many of them consider it for a temporary time. I mean, they say in the future, we want to have face-to-face visits, but for several things, it can be also online. So it's a kind of, it will be a kind of, I don't believe personally, and I think many people don't believe that we will go back to our normals, let's say so, before the COVID outbreak. So we will, I mean, I think also for the future, we will have both alternatives. But the problem is, we are, I mean, the question or the problem or the question is how much we are prepared for telemedicine or telehealth or this, I mean, remote consultations, because there are several issues and we are facing these challenges in Turkey. First of all, we don't have, I mean, you have consultations and everything, but what about the ethical and legal issues? And then what about the technology? So you have to have the infrastructure for this. I mean, the technology on one side, the ethical and legal issues on the other side, staff allocation, the reimbursement systems, the liability, I mean, of the errors and so on, the malpractice issues, when I say especially legal issues and so on. So therefore, I think we were also, before the COVID time, we were also in many branches, we were using telemedicine. I mean, the radiology, or also we are talking about the ophthalmology and so the teleophthalmology and so on. But the thing is, this outbreak has forced us to have more and more remote consultations. And I think we were not prepared for this. We have to work on these aspects. And I think this is not only in our country, in many countries it's like that. Yes, because when it comes with technologies and so, many patients are facing this challenge as well. And then also, for example, for the eye, I mean, we cannot, I mean, we cannot do too much online consultation. I mean, this is because many of the things we need equipments. We don't have this. The patients doesn't have this. So therefore, right now, although all of a sudden we are forced. I'm not speaking as an ophthalmologist. I'm thinking about diabetes management, nutritional advice, or psychological things as well. I mean, psychological support, because this is also um, big problem right now at the time of the COVID. For this, these people are forced to do it more online consultations. But as I said, the reimbursement is not there yet. Many of the patients cannot, I mean, they can manage with their phones or so, but they cannot do the Zoom meetings or things like that. So this is another problem. So there are several problems. But I think for the COVID time, this was a great solution that eased a lot of things. But on the other side, we are faced with the challenges as well, and we know better what problems we should overcome. For example, when a medical doctor, the healthcare professionals when they get a call or something like this, then they want to reach also to the medical records of the patient, they cannot do this. Then they had to write some prescriptions. Only some could do this, and so on. I mean, we had lots of problems. So, and these are problems also for the patients. I think, as I said before, we need to improve the online services and try to overcome the challenges with these online services. We should somehow find ways of training of the healthcare professionals for these telemedicine issues, and so we should overcome the legal and ethical issues. We should have resources available for these things. For the patients, especially, we should have more, think of more online education so that they can somehow manage several things themselves. Because one of the problems is the diabetes education. If there is a patient who is well educated about diabetes, they didn't suffer as much as the people who didn't have diabetes education. I mean, so therefore, we should more invest on the online services. Several things as the foundation. One of the things is there should be, because especially during the time of an outbreak, people really need help for many things. So there should be hotlines where they can reach 24 times a day. I mean, so because the thing is, I think this outbreak has shown us very nicely that we are not prepared for these emergencies. There are several things. Most important thing is they should know how to manage their diabetes, how to manage their glucose control. About nutrition, they should have good information, how they should eat and so on. They should have good information for how to check for the complications, that they should go to the healthcare professionals regularly. Or there are also things, for example, for the food, they have, if we speak about the food care, this is very important. If they can do this, manage this themselves, then they can prevent the several things, the ones and so, which may have unfavorable consequences. So therefore, in general, they should know many things. They should be well informed about diabetes, so that they can have a healthy life, let's say so. Because many of the things in diabetes, especially the chronic complications, the long-term complications, I mean, we cannot prevent them, but we can prevent that they affect the quality of life of people with diabetes. So they may have some retinopathy, but they may not have any complaints. So it's important to intervene when the patient doesn't have complications at all, but have sight-threatening retinopathy. So therefore, we cannot select topics in general. They should have good information about diabetes. At the end, they are living 24 hours with diabetes. So therefore, I mean, that's why we are saying in diabetes, the patient should be a team member in the diabetes healthcare team. I mean, with the patient at the very center, because there are many things they can improve their life with diabetes if they have, if they know how to do it, let's say so. Because there are many misconceptions and so on. And these are deteriorating their worsening, or deterioration is a not a good word, but that worsens their life with diabetes. Let's say for the eye complications, I think one of the main misconception is that they think there is no problem because they don't have any visual complaints. I think this is one of the worst and biggest misconceptions, because that way they skip their visits to the healthcare professionals or eye checks, let's say so, eye checks, I mean. So this is one of the worst misconceptions. And then some people think that because they have good glucose control, they will not have any eye problems. This is wrong, because the thing is, I mean, good control is very important. But for me, if a person is for many years goes around with a bad control of their glucose for 10 years, 20 years, 30 years, and now he or she has a good control of glucose, this is important. But on the other side, it does not diminish the threat that this person may have a retinopathy. Because if you have good blood glucose control, or control of the blood pressure, or control of the dyslipidemia and so on, then you slow down the progression of retinopathy. So therefore, it doesn't mean that you have now, after so many years of bad glucose control, you have now wonderful blood glucose control, so you don't need any eye controls, anything. This is wrong. This is one of the things. And then another misconception is, especially now with this anti-VEGFs, with the intravitreal injections, which is not, of course, this is, I mean, the people don't like it, of course. The patients don't like it. I understand this. But at the end, it opened a new era in the treatment of macular edema, especially for the ones which are involves the center of the macula. But you have, I mean, you have to inject it several times, especially in the first year. The number of the injections is decreasing in the second and third years, but at the end, especially in the first year, you have to inject. I mean, it depends on the patient, but still you have to inject several times. But people think, oh, okay, I have the injection, everything's okay now. It's not like that. And then plus, people think, oh, I have eye problem. They don't think that this is a diabetes problem. So therefore, people think, oh, okay, I had the injection, I had the laser treatment, everything is okay. No, it's not okay. You need to have a good blood glucose control, good control of your blood pressure and everything. Then it's okay, because at the end, what you have in your eye is part of a systemic disease. So there are many, I mean, these are the first three I can think of. something like this with diabetic retinopathy. With diabetes, there are also several misconceptions. I mean, some people think only overweight people can have diabetes. No, it's wrong. I mean, not all people who are overweight or obese have diabetes. This is wrong. Plus, many people are not overweight and still have diabetes. This is one of the, I think, um, uh, misconceptions. And then, because there are many misconceptions in the social life, in the medical issues, and so on, one of the most important misconceptions in the work life is, because we are trying to fight this through our organizations, is that people with diabetes are unfit for many jobs. This is a misconception. This is, I mean, this is wrong, totally wrong, because a person with diabetes who is taking good care of him or herself can have a very healthy life and can do everything that a person without diabetes can do. So there is nothing like, oh, the people are not fit for work. This is nonsense. So there are many. I mean, so with nutrition there is also, or with some people think, oh, they have started the type, especially this is with the people with type 2 diabetes. They think, oh, they have started insulin. They prescribed insulin to me, so I should be doing very bad. This is wrong. I mean, this is part of the treatment. I mean, so there are many. I mean, I mean, there are many, but the thing is, if you are well informed about your disease, then you don't have this. And you can also tell this to the other people. We can change everything with the good diabetes education, because I want to repeat this again, because a person with diabetes can live a very healthy life if they are taking very good care of their metabolic control, the blood glucose, the blood pressure, dyslipidemia, and so on. And if they have regularly their checks, eye check is one of them. But otherwise, then they may have some problems. I mean, is when you go to the primary care, you don't have the eye care because they don't have the equipments. All over Turkey, we have many ophthalmologists, so and many hospitals and clinics. So I mean, for example, as far as I know, in Canada, because I know this from a patient of mine who lives there and comes to Turkey. I mean, to have an appointment, you may have even some months, right? In Turkey, I looked to the Turkey report again. I mean, I read it yesterday. For example, some people complain of getting an appointment, but this is 1 week, a few days, or something like this. In many places, in governmental hospitals or universities, you can even have the same day. But this is difficult, not in all hospitals or so. But otherwise, you have your appointment in short time. But if it comes on surgeries, like vitreoretinal surgeries, then you have to wait. Because I mean, the number of the vitreoretinal surgeons and so on are not high. And also, I mean, so there are some things, but still the number is, the waiting time is much less than many countries in Europe. Now, I think the anti-VEGFs, especially, of course, we are also using the steroids. I mean, this is, so it's not, let's say, um, not only because we are doing more the anti-VEGF, so that's why I said anti-VEGFs, but we have also steroids. Some patients need steroids as well. So let's say intravitreal injections. Maybe it's more correct. Uh, yes, it's, I mean, the idea having an injection is not nice. But on the other side, I tell this to the people, always to the patients, that at the end you have a chance, because in the past, for the macular edema, which is one of, especially center involving macular edema, which is one of the um, most frequent um, cause of visual impairment in people with diabetes. So in the past, when there was this center involving diabetic macular edema, we couldn't do too much. We were doing laser treatment, but if you do laser to the very center, you cannot do the laser at the very center of the diabetic of the macula. So therefore, it opened a new era. So this is a big chance. On one side, it may not sound nice, but on the other side, it opened a new era. But and after they have one or two injections, they don't fear for it as much as they did before, because if you don't know something, then you are more afraid, you know. But if you have one or two, then you understand. Yes, I mean, the idea may not be nice, but at the end it's done and there is no problem. So with these anti-VEGFs, the problem is that you have to inject it many times. And then, of course, there are some, the risk of some complications, but they are very rare. Now, there are three kind of anti-VEGFs on the market in Turkey. In the past, we could use the ones which are FDA approved, and they were reimbursed. But since last year or 2 years, these are not reimbursed. We are using the off-label one. The off-label one is reimbursed. But after several injections, if the patient is not recovering, then we can go over to the other ones, then they are reimbursed as well. So in that respect, I mean, I hope we will go back to the old scheme where the FDA approved ones are used and reimbursed. We'll see. But they are all available. So with the private insurances, they are covering all of them. So the FDA approved ones mostly. If there's an indication, and if the patient has a private insurance, I mean, many times they are covered. With the laser treatment, photocoagulation, I mean the panretinal or other photocoagulations, again, if this is done in governmental and university hospitals, they are reimbursed. So the system actually is good. I mean, except that we are using the off-label one. I think we talk more about the problems. We had COVID during this COVID time, and so I mean, so it's. But on the other side, there have been very nice things happened. I mean, to overcome several of these problems. I want to give some examples. For example, when the COVID started, after I think it was in May or so, as the foundation, we have published a COVID-19 and diabetes consensus report where the faculties in several universities have contributed to its preparation. So, and this could be found, can be found on our website. So it's available to everyone, to all GPs, the family physicians, to everyone, I mean, who wants to read it. And then we started the Instagram TV for the diabetes education. So we started as 2 days a week, on Tuesday and Thursdays in the evening. So about 1 hour, sometimes it was 2 hours, but mainly 1 hour. Um, we have the board of trustees consists of all the people, all the faculties taking care of people with diabetes from all universities in Turkey. So every time we had two other colleagues who were speaking. We had a topic of the day, and they were speaking about it, and then they receiving also questions. It can be related or unrelated to the topic, and they were trying to answer them too. And then we have established a hotline. So any question from anywhere from Turkey was coming to us through our internet or several, I mean, our social media and so on. And we were forwarding this to our faculties. I mean, and they were answering it themselves. So people had direct contact with the faculties. And if it's personal questions about, because we can, I mean, we cannot manage the diabetes of a person whom we don't know, we were trying to forward this to someone from a near hospital or so, or I mean, we were trying to help them in general. I mean, so the private questions, of course, we cannot answer. They have to contact their own healthcare professionals. And then, but the problems are solved till then. I mean, so still this is going on. The Instagram TV is going on as well, but only 1 day a week. And then we had for the physicians, for the healthcare professionals, we have organized several online meetings. So this is very good, and the attendance is also very good. So we tried also to help people to access their medications and so on. For the ones who are in need, but this is especially at the beginning. Right now, we don't do this. I mean, we still do this, but as before, as much as we do before this outbreak, because in general we have the health insurance in Turkey, but still people have to pay, although a little money for this healthcare health insurance. But some people unfortunately cannot afford it. So therefore we are helping them anyway. I mean, whether it's a COVID outbreak or not. So therefore, I mean, it's, therefore I said it like this. So I think there are many things, especially with Instagram TV and so, I mean, we were not thinking about it before the outbreak, but we have seen that it's very helpful. And we have a diabetes center, and there they have started also online nutrition advice and so on. So I think these are positive things. And I hope we will improve this, and this will be more helpful